right, welcome back to Paw Patrol with your host, Dr. Jeff Dikis. Tonight, I am joined by Dr. Patrick Deheer. Thank you for joining me tonight.
Thanks for having me. It's great to be on.
Yeah, absolutely. So most people probably already know who you are, but there may be a few stragglers left in the dust who don't know who you are yet. But you're in Indianapolis, the residency director at Ascension St. Vincent, and I have a storied past of taking over the profession. Through the years, you're in line to be the APMA president. But let's talk about Indianapolis for a minute. So you're born and raised Indiana kid, went to IU and stuck around there. So what's Indianapolis like for those who've never been?
You know, I think it's the epitome of the Midwest. It's big enough, but not too big. It has all the things you would want in a big city. People are friendly. It's easy to get around. It's actually become quite a foodie city too. And of our professional sports teams, the Pacers and the Colts, and we have some minor league baseball and hockey teams too. And then we get a good music scene, a good play scene too. So some good acting, and it's just a really easy place to live is what I tell students and residents when they come through and are in the city visiting.
Yeah, I agree with that. My wife's from Indiana, so we've spent many a time, many a time in Indianapolis, and her sister used to live in Indianapolis, so we know it well. I rotated through that program. We both did back in the day. Went to University of Iowa. I'm a Hawkeye, and my wife is a Boilermaker, so we're probably not welcome in your house.
No,
Seeing as how you're a Hoosier.
I am a big Hoosier fan. We've had a rough year, but I'm hoping for a new coach maybe.
Yeah. We're having a rough year too, at least in basketball. So you had a great football season, though. That kind of balanced it out. So a little surprising turn of events there with the football program. That was awesome.
Unprecedented. I've never seen anything like that for Indiana football. It's always kind of an afterthought. You know, like we basically got football tickets when we got our basketball tickets at IU, and you just go just because. And now, like, it was sold out. The parking lots were full with tailgating. It was like being at Notre Dame or something.
That's awesome. It's amazing what some wins can do for a program. People come out of the woodwork. So for those who haven't listened to it before, I would tell them to go back and listen to Dean's chat. You've been on there a couple times with my buddy, Dr. Jensen. I think he did a fantastic job kind of digging deep into a lot of the things that, your history and your past. So if anyone's interested in that, they can go back and check that out. So let's kind of push forward a little bit beyond that, kind of think of this about kind of 2.0. You are in line to be APMA president. Is that correct?
Yes, in 2026, I'll be the 100th president of APMA.
Wow, that's amazing! Congratulations. That's quite the honor.
Thank you. It just kind of fell that way. When we're elected, we're kind of put on a track, and I was on the 13-year track. Now it's an 11-year track. So you're president in your 12th year, and that's just how I got slotted. So it was sort of serendipity, but I think it's a pretty cool honor.
Yeah, for sure. So for those who don't know, maybe some of the younger people who've heard of APMA but don't really know, kind of like, other aspects of politics, people are like, what's going on there? Can you talk a little bit about what the role of the APMA is and what the president does and things that they're involved in?
Sure. APMA is really the one that protects the profession. It does it from an advocacy standpoint and a health policy standpoint. We do other things too, but those are really our strong suits. We've gotten into research, and the research is really to support the advocacy and health policy components of APMA and defend the profession from attacks from the outside. We also are very involved with students and residents too, but it's the sort of mothership. I always kind of make the joke that APMA is like the offensive and defensive line. It's not exciting like the running backs and wide receivers are, like maybe ACFAS is or other organizations. And I'm a lifelong ACFAS member. I think it's silly that people think you have to do one or the other. You think we need to support both. But you win championships with your offensive and defensive line, and an APMA is what protects the profession. It protects our ability to practice to the full extent of our education, training, and experience, and then also make sure that we get reimbursed fairly in doing that too. So that's kind of it in a nutshell. A lot of the decisions on the governance of the profession is done at the APMA level, particularly at the APMA House of Delegates, which is in March, and that's where we transition to different leadership roles. So in March of this year, I'll become president-elect.
Okay. So when you talk about advocacy and protecting the profession, I mean, Do they have some oversight in scope? I mean, as I understand it, scope is more left to the state level, but political action committees and donating to those is very important in terms of if someone tries to come in and change something about the profession, we have people that go to bat for us and stick up for us. That's kind of what you're talking about.
It is. Scope is at the state level, but a lot of that is supported through APMA. The states are supported. They're oftentimes they need the assistance from a bigger national organization. They don't have the experience or the personnel to really fight those battles. And then also correlating that with the federal legislation is important too, so that make sure that everything's in line. We have two states that still do not have ankle privileges. We've been working with Massachusetts and Mississippi. Mississippi in particular has come up in their state legislature a couple times, and usually it doesn't happen the first time. Like any kind of legislation takes multiple types of efforts to get anything through. But we had our first victory legislatively at the federal level when I was the chair of the legislative committee, where it was the VA bill where podiatrists were moved into the physician category, and that really positively affected all their pay. So that was a big win. And then other things that have happened that have been really significant for the profession. A few years ago, CMS was trying to get podiatry, cut it out from E&M codes and give us our own E&M codes. And APMA fought that, and we won. And that was a really important victory. We were going to not only get paid less, but it was going to separate us from the House of Medicine, which is really detrimental to the profession. And then shortly thereafter, CMS changed how you could code. So previously, the way you build E&M codes made it difficult for podiatrists to bill like level 4 visits and for new patients and established patients, and level 5 pretty much never. But when they changed that, it was much more attainable for podiatrists. And so we really helped the profession at two different really important points just with E&M coding through CMS.
I remember that. That was going to be a pretty big deal, separating us out, because separating out the E&M codes kind of weakens us. It separates you kind of like a pack. You get separated from the herd and you're the weak one that the lion goes for, and you separate from everyone else. It does provide some protection in numbers. So I think that would have been a big negative for us, obviously, from a reimbursement standpoint, but also what could have come down the line from that. So I think that was not underestimated, but an underappreciated moment in our profession to kind of fight that and stand up against that. Because it's easy for us to know what we do, but I think in the general public and maybe in the legislature, they don't know exactly what we do. So having people that tell them, hey, here's what we do, and here's why we deserve to be, have a seat at the table. So I think all that's incredibly important.
And it's also another important reason that we have research. And the research we're talking about is showing podiatry's value in the healthcare system, not so much like this procedure is better than that procedure. It's more that we are valuable members of the healthcare team and we deserve to be treated as equals. Anything that gets us on the side of AMA and AOA is really best for the profession for the long term. So anything that moves us away, right now we're kind of in this crossfire between AMA in particular and nurse practitioners and physicians assistants, and we're just kind of in no man's land. And so anything that we can do to move on that side of the line with our allopathic and osteopathic colleagues is what is best for the profession long term.
Yeah, absolutely. Let's spin it forward a little bit and talk about your role as residency director and how you came into that role and what your duties are when you are named director of a program compared to just being an attending.
Sure. I was an attending for several years, and I was really most of the time third-year residents worked with me because I do a lot of rear foot surgery, and they got a lot of the rear foot cases with me. And the residency director at St. Vincent decided to step down, and the residents actually approached me about taking the position, and I had not thought about it. I had to first make sure with myself that I could handle it from a time standpoint and a responsibility standpoint, because I have so many other commitments on my time. I wanted to make sure if I was going to do it, I could do it well. And when I was interviewing for the position, our DIO, who's in charge of all the residency programs, I told him, like, if I'm going to do this job, I have a vision for this residency, and I'm only going to do it if you'll support me getting to my vision for the ultimate goal for this residency, because I thought it was a residency that had a lot of unmet potential, and it could become one of the top programs in the country. And really everything that I envisioned for it has happened over the last 6 years or so.
Yeah, absolutely. going way, way back, my wife and I both rotated through there when Dr. Rayner was there, and we were offered the program, and we had a really tough decision to make between going there or where we ended up in Pittsburgh. But yeah, we loved the program there, and I think it's different now, obviously, a little bit, but a lot of the same attendings.
Yes.
So I think it's only grown and kind of become one of the preeminent programs in the country, and well thought of. So hats off to you for doing that, because I know it's not easy. I speak with my residency director, Dr. Burns, often, and I get the behind the scenes lowdown on how difficult things can be from an administrative standpoint and all the things that come along with it. So it's a lot of extra work, and I think that goes underappreciated.
Yeah, I really love it. It's I love getting to know the residents, and actually, we have usually 4 to 6 students every month too, and every student spends an entire week with me. They rotate with me through my offices and surgeries. We have lunch together, but I grow really close to the residents over the 3 years. I almost become like my kids, and
Mm-hmm.
they're really it's an honor to be able to lead the program. We have over 50 attendings now, and we cover kind of the whole central Indiana area, and it's really become a great program. And Jeff Jensen made a comment one time that I could not agree more with, and it's not because I'm a residency director, but it's true. I think residency directors are the unsung heroes of the profession, and I
Mm-hmm.
don't think they get the sort of props that they deserve very often.
Yeah, you don't really understand what goes into all of it in the behind the scenes things. And, people just take it for granted. They're the director. Okay.
Right.
But no, you have to understand I'm trying to do this, this, and this, and be a residency director and
Right.
deal with the hospital administration and make sure all your rotations are covered. And where we got a problem with one of the students or one of the residents. I have to tackle all those issues. So there's probably always something going on, that for better or for worse, because, there's a lot of good that comes from it as well, but a lot of extra work.
Yeah. And I think teaching people how to do surgery in particular is one of the hardest things out there. It takes a lot of patience. It takes a lot of confidence. It takes a lot of, you have to be able to instill confidence in the residents, and let them know that you believe in them. You have to be able to coach them through it. It's something that is, I continually to get better at, is teaching them how to do surgery, because ultimately those patients are my patients and my ultimate responsibility. And I want to see the procedure end up how I visioned it in my head. And so I have to get the residents to kind of get to that point. And it really takes a lot of patience to teach surgery. It's not something that everybody can do, but even the attendings, I mean, I mentioned residency directors, but attendings who give back to the profession and teach the residents are so important. I think that's really one of our strong suits. We have a great, great group of attending surgeons here.
That makes a big difference. That helps a lot. So yeah, I would imagine it's kind of like trying to teach someone to ride a bike, and you say, there's the bike, go ride it. And like, I can't ride it. I need to do it to be able to learn how to do it. Can't
Right.
just tell you how to do it. You almost have to like throw the wire, feel it in your hand,
Yeah.
punch through with the drill, but not lean on it so that you poke through to the underlying structures. I mean, it's one of those difficult things that you're not teaching them how to do it unless you're letting them do it somehow. So, and that's
Yeah.
very difficult because they start at a low skill level and eventually they get better and better and better, just like everybody does, including riding a bike. But I think that's very difficult because some people pick it up quickly, some people don't. Some people need to ride the bike 100 times, some people get it on the third try, but there's a lot of variability there. And I understand. I work with students. I'm not expecting them to do much, but handing them the tools and seeing what it's like, it just brings back so many memories of like, oh yeah, I didn't always know how to throw this wire perfectly on the first try and know which angle it needs to go at. So you lose some of that perspective when you've been doing it for a while. But when you work with residents and you see people trying things for the first, second, third time, you start to appreciate that again. But yeah, it takes a lot of patience, I'm sure.
Yeah. I think teaching touch and seeing things in 3 dimension are probably the hardest things, and the last
Mm-hmm.
things that people get really fully grasped when they're learning how to do surgery.
Yeah, spatial awareness is very important, because if you can kind of picture the orientation, if you're doing a reconstructive surgery or fusion or something, and you can picture in your mind 3 dimensionally where that wire needs to go, it's a
Mhm.
lot easier to go ahead and do that than to not be able to understand that concept. Some people get it sooner than others, obviously.
Yes.
Let's talk about the best qualities of a resident. Obviously there's some simple things and showing up early. Early is on time is late. All the things that people should understand. But what do you look for when you look for a resident in or a prospective resident, I should say, when you have the students come through?
Well, grades matter, but I also think a big part of our program is the culture of our program. I really have very few things escalate to me as residency director. I would say most of the time it's handled with our chief residents and sort of
Mm-hmm.
internally with the residents. So the culture is very important. So what does the fit look like? We've had 4.0 students who wanted to be here who were great candidates, but the culture, the sort of personalities just didn't line up
Yeah.
for whatever reason. So I think that's one big thing. I think another thing that I ask every resident when, and I tell them when they start in July 1st, we usually have orientation 2 weeks before from like mid-June to July 1st. And
Mm-hmm.
then I'll have some time alone with them. And I always say, you have a couple of responsibilities here. First, I want you to leave the residency program better than you found it. I think that's really important. And I also want them to be a lifelong learner. I tell them they're going to learn probably the most during these 3 years, but it doesn't stop at 3 years. And you have to be a hard worker, but you also have to have that caveat of your own well-being. Like when you need to like get away for a minute, if you need to go for a run or play a round of golf or whatever,
Mm-hmm.
I'm not here to micromanage them. I want to support them so that they can become the physicians that they envision for themselves and give them all the resources to do that. But there's hard work involved and there's dedication, and you have to really stay focused. I ask them to every surgery to kind of critically evaluate themselves. And I think, they think of that as what did I do wrong? But I ask them to do it kind of in a different perception as what went well during the surgery, and then what could I have done differently instead of what did I do wrong? And if you think in those terms, and some people write it down. There's a thing called the after action report that's used in the military after military events where they kind of analyze how things went. And I created something for the residents to use. Not all of them do it. Some of them just kind of write it down in their notebooks, but either write it down or just doing it mentally. And that way it becomes a building block. And for every surgery, you're just building upon those things that you have learned from each surgery. I think too often residents just get in the, I'm going to do a surgery, then I'm going to the next surgery, then I'm going to the next surgery without maximizing the learning opportunity from each surgery.
Yeah, I think that's a really important takeaway. I think that's important. It's in a different realm, but I coach my son's 4th grade basketball, and every game I sit them down and I point to each one and I say, what's one thing that you did well and what's one thing that we could improve upon next time? And I think to look backwards and reflect on both positives and negatives is helpful. And I've never really thought about it from a surgery standpoint versus a 4th grade basketball, but you can kind of apply it across a broad range of things, of anything you do, of trying to reflect back and say, hey, what could I do better? Or what would I, but also taking a moment to say, you know what, I did that well, and not make it all negative, like you said. So I think that's a great way to do it.
I still do that myself too. I always tell the residents, I'm a better surgeon than I was 5 years ago. I'm a much better surgeon than I was 10 years ago. And I'm significantly better than I was 15 years ago. So like it's a continual evolution throughout the process if you critically evaluate that. And that doesn't mean negatively, like I said, but you really have to look at all the positives and what you could have done different or better for the next case.
Yeah, absolutely. One of your first year residents, Savannah Santiago, has been helping me out and producing the Pod Patrol newsletter. I'll give her a quick shout out to her. She's doing a great job. And I will give a quick recommendation. If everyone goes to podpatrol.kit.com/subscribe, you can get access to that newsletter. And Savannah's doing a great job. But I'm sure you have multiple great residents there, but I'm partial to her because she's been helping me out on my side too.
Yeah, she's amazing. And I love podiatry. My father-in-law was a podiatrist and he loved podiatry more than any podiatrist I've ever known. And Savannah loves podiatry too. She is such an amazing ambassador for the profession and for our residency program. She's a shining star for sure. There's no question about that.
Yeah, she's a first year. We can't be talking about her like this. She's going to get too big of a head. We got to Savannah, earmuffs. Don't listen to this episode. You still got a lot of work to do. I'm just kidding. All right, so let's talk about some of your favorite cases to do. So obviously you like doing pediatrics, which not everyone loves pediatrics, but what are your favorite cases to do?
I do a lot of flat foot, and I do a fair amount of cavus foot. Cavus foot's not nearly as common. And then particularly when I do international work, I've done a lot of international work over the years. I tend to do a lot more clubfoot type surgery then too for neglected or undercorrected type clubfoot. Each one of those things, I think, provides a different challenge, but kind of in the everyday, it's mostly like pediatric flat foot, juvenile hallux valgus. I do a fair amount of toe walking too. I get a lot of kids refer to me for toe walking too.
Sure. I had an idea one time for a boot. If this turns out to be a good idea, I'll edit it out and we'll make $1,000,000. But I had an idea one time for a clubfoot brace. You know how they do the Ponseti casting technique, but it was almost like a cam boot, like an articulating cam boot. Maybe they
Mm-hmm.
have something like this. But because the providers wouldn't be there to keep doing the casting, you leave them behind with this little like boot that you can rotate and click a little thing and manipulate with time. Do they have anything like that?
Kind of, not quite exactly. I know exactly kind of, I can picture what you're talking about because I've done so much Ponseti casting over the years, and there's a skill to it for sure. And some people use like the soft cast. I've never been much of a fan for that. I don't think it is. I think it is as robust as the plaster of Paris and stretching those soft tissues out.
Sure. That's a complicated thing. I mean, it's complicated here in America, let alone complicated in these foreign countries where they have limited access to medical care and there's a language barrier and a limited understanding of what's going on. And the hospital they need to go to is not exactly around the corner. So you're talking about some of those mission trips that you have been on. I think you said at least 30 of them is what you said on Dean's chat. So that's fantastic. Do you find pediatric cases to be intimidating at all? I think sometimes people are intimidated by pediatrics because, well, I don't really know why, but maybe they think they don't want to mess something up because they're still growing and there's a much more at risk. But do you find pediatric cases, probably not anymore, but at one point, did you find them intimidating?
I don't know if I ever found them intimidating. I think the thing with pediatrics is you have this other component, which is the parent. And sometimes
Sure.
the parents are more difficult than others. The
Mm-hmm.
other thing about kids is kids come to their conclusion on things on their own. So you can tell a kid, like, okay, it's okay to put weight on your foot now with your walking boot. You don't need to use the crutches anymore. If they don't believe it, you can tell them that until you're red in the face. Their parents can tell them that. They're not going to do it. And
Mm-hmm.
so they have to come to that their own understanding. Actually, one of my last patients today was a young lady. She's about 16 or so. I did a juvenile bunion surgery on her and a gastroc recession. But with the gastroc recession with a Bowman, it feels like it's pulling, and kids get really a little bit weirded out by that. They think that something's wrong, but that's just the normal stretching of that gastroc component. And you can tell them it's okay to put weight on it, but they have to be able to really fully believe it before they're going to do it.
Sure. Do you end up finding that you treat kids differently? I mean, it depends on the etiology of what we're talking about. Sometimes it's just a smaller version of an adult foot, but in other cases they have growth plates and, normally you do this, but in a pediatric you have to do something different. So do you approach pediatric cases differently with a different algorithm, or are you just kind of scaling it and in certain cases we have to make some adjustments?
Just in certain cases, like I do a lot of Evans, Cottons, Bowmans for flat feet, but like if you have a tarsal coalition, I haven't had great luck with just like resecting metal facet coalitions. People seem to still have problems with them. They seem to always be disappointing from a range of motion standpoint. So,
Mm-hmm.
particularly if the kid's older, I'll end up doing a subtalar arthrodesis on those.
Sure.
I'm not a big fan of an A to P screw for those. I like my P to A screws. I think
Mm-hmm.
when you do an A to P screw, it kind of pulls the talar head down. You lose some of your correction, but you
Mm-hmm.
really don't have any choice in a pediatric patient when they have an open physis in the calcaneus. So, I
Right.
have to just accept that I'm going to have to do an A to P screw instead of a P to A screw.
Yeah, I'm with you, and that makes sense. I'm just never excited when I throw hardware and worrying about if I have to go find it again, and that A to P screw makes me nervous having to go dig
Yeah,
that out versus the P to A screw is very easy. Just whoop, it's
it's right
out
there.
in an instant. So speaking of flat foot and all the things that come along with that, you are the inventor of an equinus brace, which people
Yes.
may know. And then recently you came out with a Bowman kit. Why don't you talk about that and kind of why you decided to do that?
Sure. The equinus brace has been out for a while now. That was an idea I had because I was using a night splint for myself and realized it really was ineffective. And so the whole point was it has to go above the knee. I partnered with two good friends and we formed a company to bring my idea to life. And it was a really interesting process because we really didn't know what we were doing. We kind of learned along the way. I think it's a great product. It really incorporates all the components of the conservative treatment for equinus. And then I do the two procedures I do by far the most are first MPJ arthrodesis and Baumann gastroc recessions. I think Bauman's for me are the better choice to lengthen the posterior muscle group. And historically, what I've used is a Sims rectal retractor to separate the muscles. And it was always not great visualization, but the two things I would see with that procedure from a complication standpoint were wound dehiscence and then also hematoma, which is much less common, but I think more profound from a complication standpoint. Mm-hmm. I think one of the issues with the wound dehiscence is the amount of tension that Sims rectal retractor puts on the skin margins. And so I was looking for something that would improve the visualization for the surgeon, but also reduce the tension on it. And then finding a way, I always tell residents when we're doing a Baumann together, I always say you have to have a light hand as you're cutting that fascial layer, not to cut into the gastroc muscle, because you have no idea how much the muscle is going to bleed. And if it causes a hematoma, it is really painful. It takes longer to heal. It acts like a DVT. It's not a DVT, but it acts like a DVT. And I always, kind of remind them, light hand as you're cutting that fascial layer. So I wanted a way to protect the muscle too. And so I formed a company with some of my three of my sons, and we developed this product with Envision and a company that makes some products I use in pediatric flatfoot. They make peak cotton and Evan wedges, and we came out with this disposable system, and it's just been out a couple of months, but we've gotten really good feedback from the people that have used it. We're going to tweak it just a little bit, but it definitely, I think, is achieving the goals I had for it when we designed it.
So if people were interested in getting that, what's the best way to do that?
Just visit our website. It's gastroc.com.
Oh, you got gastroc.com? There was no bidding war for gastroc.com? That was available?
I reserved that a long time ago. Yeah.
Smart. Yeah, that's awesome because, I've done my fair share of Baumanns. We did that. That was a procedure of choice in residency. I do most of mine endoscopic now, which sometimes is easy and sometimes I struggle and want to go back to the Baumann. How often do you find yourself releasing both the gastroc and the soleus? Are you mostly just doing the gastroc?
Yeah. So the first thing is I like to pull the plantaris out first and cut it. Doug Blackledge, who's a colleague here in Indianapolis, showed just by cutting the plantaris, you get about 9 degrees of dorsiflexion. It acts like a tether. And then I'll do one recession in the gastroc fascial layer and check the dorsiflexion. I'm trying to get to about +5 degrees. And if I'm not where I want to be, I'll do a second recession. And Herzenberg did a study that showed that you get more motion by doing multiple recessions in the gastroc fascial layer than doing anything to the soleal layer. And Baumann, when he wrote his original article in '89, actually was doing like 3 or 4 sometimes recessions in the gastroc fascial layer.
That's interesting. Very powerful procedure, and if done well, then can be rather quick as well.
Yes.
Sure, you've got it down to a science.
Yeah.
So let's jump into some cases. How does that sound?
Sounds great.
I'll let you kind of guide the ship here. But this lecture was entitled First MPJ, the GOAT of all procedures. Why do you think the first MPJ fusion is the greatest of all time?
It's been around since 1852. It has more literature than any other procedure. One of my favorite articles is a 15-year follow-up on first MPJ arthrodesis with a 96.3% patient satisfaction rate. There's no procedure in foot and ankle that has that long of a follow-up with that kind of a patient satisfaction rate. The other thing, too, is the foot can adapt to the big toe being fused to where it works the same as somebody has a perfectly normal first MPJ. And it really doesn't stop people from doing any kind of activities. Usually they can do better activities. Another study looked at like functional outcomes, and the thing that had the biggest difference between pre-op and post-op and functional outcome measures was quality of life. So you can really significantly improve patients' quality of life. It's a great surgery. I like things that are predictable. It's about as predictable as it gets, I think.
I agree with you. I'm a big fan, and I've joked around. I get into some arguments on LinkedIn with people. I should probably just go to bed, but I get into some arguments on LinkedIn with people, and people say, "When are we going to stop doing first MPJ fusions?" And I say, "When my patients stop telling me how much they love it, that's
Right.
when I'll stop doing it."
Well, I was doing them here in Indiana before anybody was really doing them, and everybody thought I was crazy. That's back when I only had a couple cannulated screws. We didn't have any plates or anything like that. And
Yeah.
so, yeah, I've been doing them for a long time. So this was a middle-aged woman. I think there is one category of patients when you're talking about first MPJ arthrodesis that you really have to have a little more of a detailed discussion with. It's women kind of between 40 and 60. And really it comes down to their shoe gear goals. This lady had what I would say is a pretty, significant bunion deformity, and I like 0 degree recurrence as opposed to whatever degree recurrence a lapidus can provide. We can debate that, but I think it's around 15% or so. And she didn't care about heels. She worked in a factory, and so then to me that's a slam dunk, like doing a first MPJ arthrodesis, and that's what I did on this patient. You can go ahead and show the post-op x-rays on her, but she had pretty significant bunion, and she healed. This is very predictable, and she went back to work in her work boots and was able to do her normal activities with no problem. So I think first MPJ arthrodesis is really thought of for hallux rigidus cases. I don't think we think of them enough for hallux valgus cases. And most of the time, if I have a middle-aged guy coming in with a bunion, whether it's moderate or severe, I'm doing a first MPJ fusion on them.
Yeah, I 100% agree with you. I have a very short leash to fuse their first MPJ, especially when it's someone who's middle-aged to older and the deviation has been long-standing, which we know then there's going to be some arthritic changes at the joint, even if they're not obviously apparent. You get in there and you do enough of these, and the joint does not usually look fantastic with a long-standing deviation. So the correction there with the pull of the adductor houses is important, and you can correct bunion and fix their pain all at once.
Yep.
What are let's talk a little bit technical details for a minute. Do you use a 0 degree plate or do you use the dorsiflex plate?
A couple things. First, I'm a 5 degree plate fan. There's really 3 options. There's 0, 5, and 10. There's research that shows that a 0 degree plate actually has a higher rate of non-union because of the increased pressure through the distal aspect of the hallux back on the fusion site. The 10 degree plates, I think, are too much. You tend to see a hallux malleus starting to develop down the line with those. The other thing, too, is the length of the plate. I get my own non-unions without question, but I fix a lot of other non-unions. And one of the things I was noticing was the plates always seem very short. And then an article came out that showed the length of the plate was really associated with non-unions. They kind of, in this article, they had what they classified as a short plate or a medium plate. And the difference was like 44% complication rate with a short plate. And their complications were non-unions or loss of correction, all these, a couple of different things, but only like around 6.5% for a medium-sized plate. So I use as long of a plate as possible. So on women, I tend to use kind of the standard length plate most companies make. For men, I almost use almost like a recon plate. They just have bigger, longer bones, so you have more to work with. And just from an architectural standpoint, it's hard to get too long of a plate on women sometimes because it just doesn't sit right. But on men, you can use a really long plate. And so that really does give you a stiffer construct.
Yeah, I agree with you. And it makes sense from a from a physics standpoint. If you're going to connect 2 overhead beams together and you use a little tiny plate, there's structurally it's going to collapse, versus if you use a long beam, spread out the forces and have more points of fixation, it just structurally makes a lot more sense.
This patient had a lapidus by someone else, and then they did a while. I'm not a big fan of any lesser metatarsal osteotomies. Those who know me know that I'm pretty much a not a fan. But this was done sort of preemptively to try to prevent second metatarsalgia. And you can see the toe still dislocated despite having a while done, and it's because of the excessive shortening. There is a little bit of elevation too on the lateral view. So this patient had a lot of sub-second pain. And if you look at the relationship between the second, third, fourth, and fifth mets, that's all pretty normal. It's just the first is really short. Now, how can we reestablish? the parabola is really an important question. If you try to do it back at the lapidus site, I think you just stiffen up the first MPJ. Plus, it's pretty unpredictable. So I would like to. I tend to do it at the first and a pre-cut graft for that fusion. And that's what I did on her. And the second MPJ, I just kind of freed up the soft tissue and pinned around all that hardware and used a nice long plate. This is kind of immediately post-op. I think there might be one down the road post-op too. You can see how I just kind of pinned around that with the K-wire for the second MPJ. But I used, this is like, I think 7 or 8 years down the line. You can see that graft fully incorporated. The second MPJ looks a little junky, but her toes down, if you look on the lateral, it's touching the ground, and she doesn't have any pain. She doesn't. She used to get a callus subsecond. She doesn't get a callus there anymore, and she's doing really well, especially with some orthotics.
I want to talk for a second about how often you put a crossing screw across the first MPJ, or if you just put the dorsal plate, because I get that question a lot, because I usually don't put the crossing screw, but I've noticed out of these two that you haven't either. What are your thoughts on the necessity of that crossing screw?
I never use it. I'm a fan of using an axial K-wire to get the temporary fixation for this. So it makes it hard to work around that, first of all. And the other thing too is I just don't like a bunch of hardware crossing across my fusion. I would like to have more bone-to-bone contact and less hardware through there. And you can make an argument it's not that big of a diameter of hardware going through the graft, the overall percentage involved. But with the compression slots on these plates, and especially if you have an axial K-wire, it acts like a railroad track where it just compresses both components together. And it really allows you to dial in the position. I think first and foremost, we have to have the position right. And if you don't have the position right with the first MPJ orthodesis, patients don't do well. So with an axial K-wire, I use a 6.2 K-wire, and I check the position both in all 3 planes. And so I'll check the sagittal plane. I want it kind of between 5 and 10 degrees dorsiflex, making sure it's not too straight. So I'll check it against I'll put the lid of a screw plate underneath it. And then on the medial side, and just making sure there's no rotation. And if you have a K-wire and one of those things are a little bit off, you can just bend the K-wire to get it where you want. You don't have to rerun it. It's a really easy way to hold everything together while you then just put on the final fixation.
Mm-hmm. I agree with you. Another interesting component, you said her second MPJ is non-painful, which is all we care about,
Right.
But it doesn't look 100% fantastic.
Right.
What would you do in this case if she did have second MPJ pain?
Yeah, when you have an arthritic second MPJ, I don't think there's a lot of great options. I have become a fan of interpositional arthroplasty and just pinning them. So I'll do like maybe a partial head resection, and then I'll just use a dermal graft and accordion it and sew it in. And then I do like to pin the toe and let everything scar in straight. That would have been my next approach there.
What are your thoughts on hemi implants and or second MPJ fusions?
I'm not an implant fan at all. I wrote a whole chapter in a book why I'm not a big fan of implants, and that applies to the second or lesser MPJs also. I have not done a second MPJ fusion, but I got to tell you, I've thought a lot about it. There's only 1 or 2 papers out there on it. I think the biggest challenge for that is really adequately fixating it. I don't know that there's a great plate system for it. But especially if you have these really dislocated MPJs with no plantar plate left, and it's just kind of all over the place. It's very unstable. I think that can actually be a really good option. I just haven't pulled the trigger on it. I think it's mainly because I don't know that I'm comfortable with the available fixation for it.
I've done it a couple times before. I was the same as you. I was a little nervous, and I talked to Sean Grambard about it, and he said he's done it numerous times, and patients have been happy. I think that the caveat to that is that it's also in the setting of a first MPJ fusion. So they're not going to notice that much because the first isn't moving. If you did an isolated second MPJ fusion, I think that would be structurally very difficult to stabilize. But I just put a dorsal locking plate on there, just kind of like you would fix maybe a metatarsal shaft fracture. And it seemed to work well, and her pain was gone. So I just didn't know. Some people are kind of anti. I think some people are taught like, oh, don't fuse any of the lesser MPJs. But sometimes you don't have any other options. You see these patients, you're like, what else am I supposed to do? The interpositional arthroplasty, you've had good success with that?
Yes, I have. Luckily, I don't have to do it very often, but I'll do 1 or 2 a year of those for whatever reason. But they work pretty well. But I've thought long and hard about the second MPJ arthrodesis, and that gives me a little more confidence maybe to try it next time.
Yeah, the couple I've done well. Speaking of implants, sounds
Mm.
like you're a big fan, huh?
No. Yeah, this is a BioPro Hemi, and you can see how it's eroded away the metatarsal head. And we got in there, it was just like this really soft, kind of mushy material over the metatarsal cartilage. And this is kind of why, with like total taluses, now it's being done with a tibial component, and you're not having that talus against the tibial cartilage because it just erodes it away. And so here we just took out the implant and cleaned up the metatarsal head and prepped it. We had some shortening because of the erosion of the metatarsal head, and then put a graft in there. And I have an axial KOR, which you can't see in the picture, holding everything together. And I like to soak my allografts in BMAC, concentrated bone marrow aspirate. And then I use as long of a plate as possible. One sort of tip on when you use an interpositional graft like this, I think it's important to put a screw in the graft because you have 2 points of healing here. The distal graft host interface is probably the most problematic. If you just have screws on the proximal phalanx and metatarsal side, you can get some micro motion from the graft still, even though it's under compression. And I think that distal graft host side can be problematic from a healing standpoint. So I'll put in my distal screws first, then my compression screw, and then I want to get at least one screw in the graft. It really helps to stabilize it. And now what I've gone to is actually biplanar plating for whenever I use a graft. I'll use a really small, like a mini plate along the medial side with 2O screws, which I think is in the next case. It shows a picture or some x-rays on that, but it's a more stable construct even than this, but a really long plate here also.
I agree with you. Point of fixation in the graft. Is that a graft that comes pre-contoured?
Yes. Yes. And so they match the reamers.
Okay, that makes sense. I've had some that aren't pre-contoured before, and I drilled a K-wire in it, and then I reamed it on the back table. I did the convex and the concave, and then I slid it in there. It worked pretty well, but much nicer to have a pre-contoured that just slides right in there. Is it based on the width? You kind of understand how much, or length, I should say, not the width, the length of bone loss that you need?
Right. They have trial sizers, so you can kind of see where it is in relationship to the second. You can either do it under CR, or I just do it by kind of palpating things and then looking at it clinically too.
Yeah. So you have incorporation of the graft there. Have you ever seen any of these fail?
Oh, yeah.
You know, someone might say, okay, you're taking a dead piece of bone, trying to reincarnate it and put it in there. Why would it magically come back to life? And obviously sometimes it does, but what would you do if it didn't incorporate or didn't work?
I think as long as you keep it under a centimeter, it works most of the time. I think when you start going above a centimeter, the creeping substitution sort of is reaching its maximum efficiency. Bone stimulator can really be helpful optimizing their health, like with vitamin D supplements and things like that. Another thing I've been using more recently I do a lot of fusions of all types, but if I have a non-union, I've been using teriparatide, which is a parathyroid hormone. It's used for osteoporosis. Most of the biophosphates they prevent bony resorption. Teriparatide actually causes bone activity to occur. So there's a lot of decent research on it for non-unions and fractures, and now it's starting to be used for non-unions and surgery, particularly fusions.
Interesting. Makes sense.
I think this is an interesting one. This patient had a MIS surgery about a year before she came to see me, and her son-in-law is a podiatrist in a couple states over, and he told her to come and see me, and you can see the problems here. And I do minimal incision surgery. This is not hating on minimal incision surgery. That proximal screw is below the metatarsal head, so it completely missed the metatarsal. And if you look on the AP, that more medial screw, I think, fractured through the cortex. And so basically there was very little fixation in the metatarsal head. She had a confirmed non-union on the CT scan. And she also still had a pretty painful first MPJ with limited range of motion. That certainly could be due to that proximal screw, but I thought there was some elevation that occurred and it wasn't very predictable. The one thing I had going for me in this case was the length was okay. She wasn't, her parabola was okay. So what I decided to do was to just do a first MPJ fusion, but also repair the non-union directly at the same time. And The way I did it was I prepped the first MPJ. I left the hardware in first and prepped the first MPJ. It gave it a little bit of stability for me to do that. And then I took the screws out, and then I went back and prepped the non-union site, freshened that up and drilled it and put some biologics. And then you can see my axial K-wire through the toe. Then I put 2 other K-wires through the non-union site. And the next x-ray, I think, shows a drop fluoroscopy of the fixation. And so there you can see the fixation. I have you can see how long that plate is. That plate's almost back to the metcuneiform joint. So it's a really long, robust plate.
So this is similar to the last one that had a bony defect and you put in an allograft. This is an autograft essentially of the same thing, a space occupying autograft, and it just happened to be a non-union of the head of the first metatarsal.
Yeah. And then I did use the biplanar plating on her, and I've been using that whenever I have a revision. And you can see the smaller, like 2.0 plate on the next slide there with the dorsal plate in place. And I use 2mm screws, and those have offset drill guides. So if one of your screws is hitting one of your dorsal screws, then you can just use an offset drill guide to kind of get around it and get most of those screw holes filled. I like to use a 9-hole T plate where I'm getting at least 2, maybe 3 screws in the proximal phalanx, 1 or 2 in the graft, and then the rest in the metatarsal shaft. I will say when I'm doing biplanar plating, I do have to take the hardware out more frequently. And so on this lady before,
medial hardware irritation,
all of it, it just feel it, pressure from shoe gear. On this lady in particular, I got a CT scan before I went in to take her hardware out because she was complaining of pain, to confirm that both sides were completely fused.
What's your thought process for biplanar fixation? I mean, structurally it makes sense, but you find it to be necessary. The plates I've seen that you're using are polyaxial, as opposed to, I don't love it when people just use a straight plate and just all the screws are in one axis. It makes no sense to me. But using a plate that kind of hugs to the bone and the screws are polyaxial. But what's your thought process for needing that additional stability? You just like that in your revisional cases because you're going to throw the kitchen sink at it?
It's just orthogonal plating is more stable, and with the graft in there, I think anything that you can do to stiffen up the construct improves the odds of that graft incorporating.
Sure, makes sense. These people find you, don't they?
This one actually didn't turn out actually as I hoped. It was a tough case, and when she first came in, I essentially recommended a transmetatarsal amputation or a first ray amp. But she's kind of like in her 60s and wanted to try to salvage this. She'd had a first MPJ fusion by somebody else, and then it had a non-union, and then somebody went in and repaired it. That got infected, so they went in and resected the bone, and then this is what she was left with. And of course, she was having all kinds of lesser met pain here. And so I kind of thought a lot about this and how can I get some of the length back here. So I decided to do a graft distally. I was worried about that osteolytic area in the phalanx, and that ended up being just fibrotic, cruddy bone. So I had to use a much bigger graft than I was planning on. I wanted to try to keep that to like a 10mm graft. And then I wanted to use a mini rail to lengthen proximally at the base and span the first metcuneiform joint with my 2 proximal pins. And then lengthen just behind the plate, and that's what I ended up doing.
So mini rail external fixator on there and getting some length out of that, and then fusing the first MPJ.
And then I thought, as we're doing a distraction lengthening, that it's going to help compress the arthrodesis site, that it would improve the odds of that healing. And so the first week, you just have it compressed, and I started doing distraction 0.5 millimeter a day. I'd have her do a quarter turn twice a day. And then what we ran into with her was she'd had so many surgeries. She developed a wound dehiscence, and the plate was exposed. And I sent her back to him to try to deal with the exposed hardware. And it got to the point where it really wasn't healing over. And she essentially decided to go ahead and go with a partial first ray amp. So unfortunately, this didn't work out and kind of ended up where I recommended from the beginning. Actually, I just saw her yesterday. He sent her back to me to get some orthotics. That first ray partial amp's all healed up, and she's just needs some orthotics to try to protect the lesser rays now.
So obviously you have the best of intentions here, but sometimes the patients have poor protoplasm and, someone who's going to have an infected non-union bone resection. I mean, that's an uphill battle to begin with, but
Yeah.
so sometimes you have the best of intentions and it's nothing that you do. It's just sometimes sometimes things don't go our way.
Right. And this is with her lengthen out. And you can see I got good length, but
Yeah.
when that wound hissed, and then we had probably about a centimeter or so wound on the dorsal aspect right over the plate. It was difficult to get that to heal over.
Yeah, that's a bad day when you stare at metal in your office.
Yeah.
It's luckily few and far between, but when you see metal in your office, that's a bad day
Yeah.
for you and them. All right, let's change gears for a minute and talk about some of these flat foot cases that you're passionate about and do so many of. These can be very, very challenging cases, and each one seems to be a little bit different than the last one. You think you have your algorithm all worked out, and something new walks in the door that you haven't seen exactly before, and you have to scratch your head and figure out what to do.
Yeah, that's for sure. This one, this is just kind of a case where there was a misdiagnosis. Basically, this was a 19-year-old female. She'd had surgery by somebody else on both feet and the right foot. They did an Evans, a gastroc recession, a Cotton, and a Kidner. Did the same thing on the left foot. The left foot continued to have pain, so they took her back and did a medial calcaneal displacement osteotomy and a FDL to PT, which in a 19-year-old, you kind of have to, question that. The right foot did okay, and I could live with the right foot results, but the left foot really continued to bother her. And what ended up happening was her left foot, she had a middle facet coalition that was never diagnosed. So they were doing all these flexible flat foot procedures on a rigid flat foot. And that's why she never really had any luck on her left foot. So I took her back in and converted it to a subtalar joint arthrodesis. I resected the coalition, got the hind foot in the correct position, did a subtalar arthrodesis. She still had some residual varus in the forefoot, and I just did I think I did a lap of cotton on this to get the first ray down more to correct for the forefoot deformity.
Yeah, I'm always suspicious whenever you see the posterior aspect of the calcaneus ride right up into the posterior aspect of the talus. That makes me a little suspicious. And then that sclerotic change at the midfoot. Sometimes it's nothing, but sometimes it's something. So, I mean, it's easy to, with hindsight's 2020, it's easy to say, oh, look, you missed that. But sometimes things just aren't quite right on X-ray, and it's worth diving a little bit deeper sometimes.
Right. So here you can see with the cotton, I usually use about an 8mm wedge, sometimes 10, but most of the time I'm using an 8. And then if I'm doing an isolated subtalar arthrodesis, a lot of times I'll do this delta construct for my screw fixation instead of the two parallel screws. It's actually been shown to be a little more stable construct. And if I'm doing isolated, I do a lateral approach. I do a lot of medial doubles. So if I'm doing a medial approach, I'm usually going to do parallel screws.
Mm-hmm. So is that... It looks like it's lateral calcaneal wall and then thrown up into the talar head, essentially.
Yep.
And your thought process is just having a different axial construct. Just polyaxial is more stable, more supportive than. I don't like it. It looks so nice when you throw those two parallel subtalar joint screws, but structurally it's not as strong as if you were to make them convergent or divergent. So I see it all the time where it looks nice to have the parallelity to them, but actually you probably want them offset a little bit.
Yeah. And there was a good study where they looked at like different screw orientations. They found that that sort of arrangement was the most stable. This patient was a 58-year-old guy who'd been in AFOs for quite a while, and was referred to me because he still worked, but the AFOs were no longer really functioning well for him. And he's a big guy too. You can see his soft tissue envelope. Basically, his talus was sitting beside his calcaneus. They weren't on top of each other. And this is about as bad as I think you'll see for like a non-Charcot type deformity. You can see on the AP, the navicular was starting to split in half. He had complete dislocation of the TN joint. Luckily, he didn't have any ankle valgus. He had subfibular impingement, and then that's a hindfoot alignment view shown. That's about as maximum hindfoot valgus as you'll see.
Yeah, that's
So
tough.
I started doing
That's
what I
tough one.
Yeah, I started doing a lot. I've started doing a lot of what I call a medial triple, which is what I did on him, where I do the subtalar TN and NC. I've always been a little bit reluctant on NCs previously because I think it's a little tricky joint to prep and then to fixate. But I do think staples have made it a lot easier. So I like to combine staples and plates, medial column plate here. One trick that I've sort of used for any planar joint that I picked up from Jack Schubreth when he was talking about doing lapidus, I just run a saw through the joint, right through the center of joint. So I'm not actually resecting the bone. I'm just resecting the cartilage with my saw. So I'll engage the windlass mechanism and supinate the foot to close down the NC joint. I do use a bigger saw blade for that than like I would for a lapidus, and then just run it through there and plane it 3 times. And that almost gets all the cartilage out of there. You may have to clean it up a little bit with like some hand instruments and then fenestrate it. But so first thing I do is prep the TN joint, and then I'll prep the subtalar joint, then prep the TN joint, and then temporarily fixate the TN. And then that almost sets your hindfoot for you. And then I'll put my temporary fixation in my subtalar joint, then permanent fixation in the subtalar joint, partial permanent fixation in the TN, and then I'll go do my NC and prep that and pin it to the stable construct of the hindfoot, and then put in the staples. And then the last thing I'll do is that medial column plate. On this guy, you can still see some metatarsus primus elevatus. I wish I would have done a lapicotton too. And I've just recently done that where I've fused all 3 of the joints. It's not easy to do all those because of the anterior tib tendon gets in the way. But this guy, retrospectively, I wish I would have done that. But he actually, that looks like a totally different foot than where it was before.
Yeah, absolutely. I agree with you. That's an interesting thought to do the naviculo-cuneiform joint, because sometimes I'll do a triple or a double, and you'll start to see that sometimes they have it ahead of time and sometimes they don't, but that NC fault, that little almost like a little mini collapse at the NC joint. So structurally stabilizing that, bringing your construct, kind of like we were talking about with a longer plate of a first MBJ fusion, why a longer plate makes sense from that. This makes sense as well. As making a longer construct and stabilizing more of the midfoot makes a lot of sense to me.
And the other thing on those, I'm using now, I'm using this really big, robust staples, and I'm using longer, bigger screws in the medial column. Like it's almost like rebar is kind of the way I think of it. I don't think you can put in too much fixation. It's interesting. On a lot of these international trips I've been going on the last few years, I've been going with some orthopedic with an orthopedic group. So I'm with a lot of foot and ankle orthopedic surgeons, working side by side with them, and like there isn't anything such as too much hardware for them. Like they put in a ton of hardware, and I put in my fair share. But like now, I'm using longer, bigger screws, bigger plates, bigger staples to stabilize all that.
Well, you see enough things fail with time, and you're like, all right, let's skip the first part where it fails, and let's just jump to the second part where I put in beefier fixation that's going to be stable. So.
This is an interesting case because this demonstrates how a bad lapidus can really affect the hindfoot. This lady had a lapidus done where they had quite a bit of shortening, and then they had a non-union too and some elevation, and it actually started causing her hindfoot to pronate and to go into a valgus. Her other foot had a completely normal arch, so all the changes in the hindfoot were due to this short, incompetent first ray. And she also had a painful first MPJ. So I decided, I'm a big fan of staging things. So I staged this on her. So I did the hindfoot stuff and then waited about 10, 12 weeks. And there's her AP ankle. She had no valgus and tilt of her ankle. And then just, you can see the hindfoot valgus on that long axial calcaneal deformity view. And then, so I did a medial double on her. And then I did a non-union repair of the lapidus. I knew I needed to lengthen the first ray, but again, I wanted to kind of keep that under the 10 millimeters. So I used an 8 millimeter graft here. I knew I was going to come back later and fuse the first MPJ, and I could get more length with another graft there. So I kind of lengthened at both sides. If I have a non-union of a lapidus, I like to do an M1 to M2 screw to stiffen up the construct, plus a longer plate. Sometimes when I do a T infusion, I think you're okay using one screw in the subtalar joint as opposed to two, because the TN joint prevents rotation. When we do a T infusion, you get about a 93% reduction in subtalar motion. Now I'm probably adding a second screw just because I've had some subtalar non-unions. I don't know that the second screw is for compression as much as rotation, but even with this, I'm probably putting in some more second screws in the subtalar joint. You just kind of run out of room, especially if you use 3 staples like this. There isn't a ton of room in the talus.
Right.
So this was, up to about 10 weeks or so. Then I took her back and did the first MPJ. So you can show those next set. And that's a ton of hardware. So then I put another graft in the first MPJ of about 8 millimeters, and I got her back out to length. I did an MIS fifth metatarsal osteotomy. That was kind of bothering her over there. So that looks like a ton of hardware, and it is, but you can see the alignment of the medial column is really well aligned. Her arch looks much better. She wasn't, that first MPJ was no longer painful for her, which was before, and then the non-union was healed with the bone graft. And that M1 to M2 screw, oftentimes that breaks, or sometimes that bothers people and they have to take it out. So I think I did go back in and take that out.
Yeah, that's a tough one. I mean, it starts with a non-union of a lapidus, but it's certainly much more than that, because you could have just gone in and fixed the non-union of the lapidus and saved yourself probably a lot of headache and a lot of time. But I think you're right. To not address the progressive flat foot deformity would have just led to some other compensatory issues and continued pain. So I think that's the way to go, is to address all the issues, especially if they're painful, not just addressing things that aren't necessarily painful, but that makes a lot of sense. All right. I think we'll wrap it up there. That's been a fantastic trip down first MPJ fusions and some complicated flat foot corrections there, and it's interesting to see the things that aren't so cookie cutter and just go smoothly. Look, flat foot, I fixed it. Look how great it looks. I mean, it's so much more interesting to tackle these complicated things and non-unions, whether they're yours or mine or whoever's. They're out there, they're going to happen, but being able to address those things is very important.
Absolutely. It keeps it interesting.
Yeah, for sure. So I appreciate you hopping on with me tonight on Pod Patrol. Thank you for your time.
Thanks for having me. It's been a blast. Appreciate it. You're doing such a great job getting a lot of information out for people. Everybody really enjoys your podcast, and they learn a lot from that.
Thanks. I really appreciate that. I get paid $0, so I must enjoy doing it. So I appreciate the kind words, but thanks for your time tonight. Thanks everyone for joining me on Paw Patrol. We'll see you guys next time.
Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.